Assalamu alaikum. Today we are going to discuss laparoscopic radical nephroureterectomy. Before going to the case, let's have a case summary. It's a 55-year-old lady who didn't have any comorbids, presented to us with hematuria on and off with clots. Sometimes she had pain. When there was pain, there was no hematuria, but when the pain was subsided, then she had hematuria. Cystoscopy was done in another center, which turned out to be negative, so we proceeded with cytology, which was also negative, and a CT urogram showed a mass in the left renal pelvis. So we went in with the ureteroscope and took a biopsy, and it turned out to be a low-grade TCC occupying the renal pelvis and the upper ureter. Here's the CT urogram. The pictures are a bit hazy because I had to include all of them. So it has a mild hydronephrosis, a small piece of clot in the renal pelvis, along with a space occupying lesion in the renal pelvis, and it is also extending a little into the proximal ureter, just below the PUJ. So there is delayed excretion of the kidney. Coming up to the steps of laparoscopic nephrectomy, so we have the colon mobilization. I have discussed the mobilization of colon and other steps in my other videos. However, here I intentionally included the video of mobilization of the colon here too, because the adhesions are a little more as compared to all the other nephrectomies that I performed. So these adhesions are of the colon with the peritoneum, and we are going to see how much has the adhesions been adherent to the colon, so much so that even some part of the gut is obscured behind it. Here we can see I have to be very careful, and this line of dissection of the colon is extremely important, because as we know, here you can see the gut behind it, so care must be taken not to cause any injury to the gut here. So that's the gut peeping out. So we just pull the adhesion upwards away from the gut so that the energy source does not cause injury to the gut. So the important thing here is while doing this dissection, one should not be going behind the kidney, because once you start dissecting, one usually goes along the lateral wall of the abdomen, and as there is pressure inside the peritoneal cavity, the gas is doing the dissection one step ahead of the surgeon. So if you do a dissection which is very close to the abdominal wall, at times one just goes into the space as the gas dissects in advance, and it leads you towards the abdominal cavity, and hence one usually goes behind the kidney, and in which case the kidney will just drop down towards the abdominal cavity, and then it will be very difficult to dissect. So as we see here, the gut is being cleared off the adhesions, and the planes become more and more clear now. So this is this place where we need to readjust our colon mobilization, because if I follow the lateral wall, it will definitely lead me posterior to the kidney, and then it will be difficult because the kidney will be dropping down upon the gut. So the dissection will become more and more difficult. Here we can now see that we are developing a plane which is not behind the kidney but anterior to the kidney, so that the kidney does not drop down. However, I must say that a little bit of dissection has been done by the gas, and the kidney has been a little mobilized from the lateral wall. However, what is done is done. We will try to prevent any further progression of this process. So we have started mobilizing the colon once again near to the border of the colon, the descending colon. Mobilization of the colon is as usual. From the crurum of the diaphragm on the left side, of course, towards the pelvic brim. But here we are going to perform a nephroureterectomy, so we will dissect the ureter as low as possible. Since the CT report also showed some cystic lesions in the adrenal gland on the ipsilateral side, we have to remove the adrenal as well. That's why the dissection towards the crurum of the diaphragm is extremely important step, because the more precisely we dissect towards the crurum of the diaphragm, the more easy it will be to take out the adrenal gland. So we have further dissected the upper pole of the kidney, or the colon. Here you can see that the kidney is already mobilized because of the gas dissection. So we do not want to go any posterior. If I go a little bit more posterior, or just follow the line of dissection that the gas has been doing for us, the kidney will drop down and then trouble. So we will dissect the ureter as lower down as possible. And for that mobilization of the colon, here you could see the iliacus muscle. Usually we stop here during mobilization of the colon in radical nephrectomy or simple nephrectomy. There you can see the ureter very clearly. But here we have gone below the sacroiliac joint. So taking that plane along with us, dissecting the colon even further. As I said earlier, that the mobilization of colon has already been recorded and discussed in the previous videos. However, here the adhesions were a little different, and the dissection and mobilization of the colon is more extensive as compared to the dissection that is performed during the process of, or the procedure of simple or radical nephrectomy, where we do not take the adrenal gland, and removing the length of the ureter is not of any clinical importance. But here we have to take out all the ureter. So we dissect slowly and gradually towards the medial aspect. Now again coming to the upper pole. Here care must be taken not to injure the splenic vessels. As we all know, the splenic artery travels along the upper border of the pancreas, whereas the splenic vein travels behind and posterior to the pancreatic gland, and there are chances of injury to these vessels as they go directly to the hilum of the spleen and are usually lying over over the kidney. So here you can very clearly appreciate the pulsating white structure. This is most probably the splenic artery along with the splenic vein. However, they are so lower down, it is not uncommon to find a superior mesenteric artery in this location. As it is not coming to the kidney, it is quite away from the splenic hilum. Most probably, this was the superior mesenteric artery and vein. However, any vessel which is not coming to the kidney must be saved. Especially, this is the problem on the left side, because on the right side there is only one artery which is originating from the aorta, and that is the renal artery. But on the left side, one can encounter superior mesenteric artery and inferior mesenteric artery, and of course the splenic artery is also there at the tail of the pancreas. So we are coming down. So the colon has almost completely been mobilized. So the next step will be to dissect the ureter. A little bit of adhesions remaining, so let's take them down as well. So the identification of the ureter and making a window. Here the ureter can be seen giving nice peristaltic movement. However, you can see that the field is red. My utmost try is not to make the field red here, because once it becomes red, it's very difficult to identify the ureter. So a nice window has been made. At this point, remember, we are not going to clamp the ureter. We usually clamp the ureter very early in nephroureterectomy for the upper tract TCC, especially the renal pelvis. So now the lower pole mobilization. We are going to mobilize the lower pole. Some more dissection of the adhesions here. There's exchange of small vessels. So we put in another port, 5 millimeter. This is called assistant port, and it helps retracting the ureter and the kidney so that the surgeon can use both his hands or his instruments. So we were talking about the clamping. For the risk of contamination or spillage of cells, we usually clip the ureter very early in the procedure. However, if we clip it early, in this case here you can see the edge of the adrenal gland. So we will dissect outside that adrenal gland in order to later on do the adrenalectomy. So the point I was making was that it should be clipped the ureter after clipping of the vein. So the dissection of the hilum is the next step in left radical nephrectomy, because if you clip the ureter before clipping the vein, the kidney is usually a good functioning kidney. It is producing a significant amount of urine, so there will be engorgement. Dissection will become difficult, and this will increase the risk of spillage again. So here we can see the gonadal vein coming to the renal vein, and we have just seen the adrenal vein as well. So let's dissect the renal vein first as a general principle, and then we will see what are we going to do about the artery. We usually clip the artery first, as everybody does. So after clipping the artery, we will clip the vein. The rest of the procedure is almost the same as described in previous videos of mine, asking the assistant or the cameraman to make the psoas muscle horizontal on the screen to correct the zero. So this is some lymphatic tissue which is coming in our way. So we have decided to dissect the gonadal vein and then clip it and then cut it and then proceed towards the artery. Although I was intending to remove the gonadal vein along with the specimen, however, a modification to the strategy is always on the table. So we clip the gonadal vein, then buzzing with the ligashore nicely. Okay, readjusting the assistant, the traction by the assistant. So we dissect the renal vein posteriorly in order to find the renal artery. But as you can see, there is a bunch of veins, and I clipped the lumbar vein as well, because the artery is usually located in between or behind the lumbar vein. In case of simple nephrectomy, we usually do not encounter any lumbar vein because we are dissecting lateral to the gonadal vein. However, as oncological principle, we have to be on the aorta so that we can dissect the lymph nodes as well. After spending almost half an hour at the same point, I decided to go through the lymphatic tissue, and the bunch of lymph nodes that are remaining I will remove after completing the procedure, because at this moment it is not letting me deal with the artery, which is a big problem. We cannot do anything unless and until we have dealt with the artery. We cannot do the vein, we cannot clip the ureter, we cannot do a lymph node dissection. Now, the lumbar vein has been clipped and divided between the clips, and some of lymphatic tissue remains on the aorta. We just leave it at the moment and we'll come back to it. So here we can see a small artery, although it was not visible on the CT. However, we have found it. There is a small renal artery alongside a bigger renal artery. So the lymphatic tissues around the aorta, which are right in front of the origin of that small artery. So we'll dissect it, we'll burn it, and then we will cut it in order to reach at the root of this artery. As a general principle in dissection of the artery anywhere, it is said that the more you dissect the lymphatic tissue around the artery, the more length you gain. So applying the clips becomes a little easy, and dividing the artery becomes easy. So we are done with the smaller artery. Let's now find the bigger one. So it's the lymphatic tissue around that artery that we are doing, and in doing so we are trying to achieve more length of the artery so that we can clip and then cut in between the clips. So as you can see here, the artery is quite clear of the lymphatic tissue and the length is now acceptable. We can see the fusiform origin. Posterior dissection of the artery by the right angle. So we have applied a clip. Now is the right time for the ureter to be clipped. Now let's deal all the veins. There's a adrenal vein, a small vein which is draining into the adrenal vein, and then the renal vein. Start clipping them one by one, nice and slow. Clipping the small one as well so that it does not bleed retrogradely. However, it was quite strange for me that when we cut the renal vein, there was a retrograde flow. So we cut it in small portions, not the whole vein in one cut, so that it does not retract. So the vein is done now. So we apply more clips on the artery and just cut the artery as well. Once this is done, the rest of the procedure becomes nice and so now remains the upper pole, the undersurface, and the adrenal gland. So the clue or the difference between a simple nephrectomy, a radical nephrectomy without adrenalectomy, and a nephrectomy with adrenalectomy is that after clipping and cutting the hilum, we then start following the upper pole of the kidney. However, where we want to intend to remove the adrenal as well, then we follow the psoas muscle. Here you can nicely see the splenic vein on the posterior surface of the pancreas. Now you can imagine the dissection that I was doing at the start of the procedure, trying to mobilize the spleen along with the colon and exposing the crurum of the diaphragm. That dissection has helped me a lot here. So always keep in mind and remember, mobilize the spleen as much as possible and as much as up to the crurum of the diaphragm. Here, as you can see, we are following the psoas muscle, not the kidney. So following the psoas muscle will lead us towards the removal of the adrenal gland as well. Same is the case with the undersurface of the kidney. You can see the psoas muscle being cleared of the fat and the adrenal tissue. So the upper pole and the adrenal gland is done. And one can very clearly see the branches of the inferior phrenic vessels and nerves. So dissection of the undersurface is as important as dissection of the spleen. Now you will see that the dissection of the lateral aspect becomes very easy if you mobilize it in a good manner from the undersurface. Here you will, after cutting the peritoneum, you will find that we straight away go into the space here. Here you can see that we dissected from beneath or from the undersurface. So they say that their dissection of the lateral aspect can be a 20-minute procedure or it can be a 5-minute procedure. If we want to do a 20 minutes procedure, keep on dissecting from the lateral aspect towards the medial aspect. If you want to do a 5 minutes procedure, so do your hard work and dissect the kidney from the underside aspect. And this will help you mobilize it from the lateral aspect in a few minutes, as one can see very clearly here in this case. Taking care of the external iliac vessels, common iliac vessels, we have completely mobilized the kidney along with the adrenal up till the pelvic brim. So after doing that and mobilizing the ureter a little further, we'll apply another clip on the ureter, just a precautionary measure, not to do a spillage while retrieving or pulling the ureter along with the specimen in the left iliac fossa. So it's been clipped now. Now the remaining lymph nodes, as the case is a low risk, so the lymph node dissection may not be as necessary as in intermediate or high risk. However, research has shown an increased incidence of survival and also prognostic benefit. So the lymph node dissection or the template of lymph node will try to remove. It is important to have a minimum of 3 or at some in some research they say a minimum of 8 lymph nodes are required in the template region. So we will try to have as much as possible. You can see the nerve behind the lymph node. While doing lymph node dissection, one must keep in mind that the origin of the nerves, they should be protected and kept in mind. So we'll apply a clip distally in order to reduce the chances of lymphoria, and then we will take these lymph nodes. Remember, this is that tissue which was preventing me from dealing with the renal artery, so I had to leave that behind. So we dealt it later on. We apply another clip here, and there is a clip which was applied to the lumbar vein. So we apply another clip just to be on the safe side, and then we cut distal to that clip. Nicely done. So here small bleeders need to be coagulated. One can see the arteries, the vein and everything. Now we have to come to the ureteric resection. So the right orifice is identified, then the left orifice is identified, and then a transurethral resection or taking the bladder cuff along with the ureter is proceeded. So we do it with the Colon's knife. It's a hot knife. We usually do it with coagulation. At times cutting is required until we see the bladder fibers, muscle fibers, and then the perivesical fat. Once we see the fat, we go to another area and try to dissect deep as previously in other region. So this also leads us towards the perivesical fat. So all around the perivesical fat is visible. Now it will be easy. We will just pluck the ureter out. Some people usually take a stitch from the outside before plucking the ureter out. They pull the ureter so the bladder comes near to you, and you take a U-shaped stitch beside the ureter. And when you remove the ureter, you make this U a figure of 8, and you just close it. However, majority of the surgeons do not usually close it and keep the catheter for 10 days so that it heals. And now we retrieve the specimen through the Gibson incision. Iliac fossa here. The muscle is cut in the line of incision, then the peritoneum is open, and we retrieve the specimen wrapped in an abdominal gauze, and then we just pull the ureter and see for any bleeders. Hemostasis is done, and then we close the abdominal cavity, and a drain is put in the renal bed as well as in the pelvis, just to be sure if the one drain is not functioning, the other must work. So you saw the specimen. It was a nice specimen, starting from the adrenal up till the ureter, distal ureter with the bladder cuff, and this is the histopathology. So the adrenal gland was clear. The pelvis tumor was confined to the pelvis, and we took a lot of lymph nodes, 3 in one specimen and 15 in another specimen. All of them were clear. One was just showing a reactionary inflammation. So that is the histopathology. And thank you very much for watching. Thank you.